but the pressures remain the same, right? Have a great product, attract physicians, attract patients, get paid for it, right? And if you kind of capture less value than you create, then you will always beat the incumbency that just like is foundationally disadvantaged when they cost more, aren't changing, and are not nimble enough to compete with you on a different playing field than they're used to.
Welcome back to the Fitt Insider Podcast. I'm your host, Joe Veneri. Today I'm joined by Nick Aubin, co-founder and CEO of Commons Clinic. In this episode, we discuss building a vertically integrated, tech-enabled specialty care platform. Nick shares how Commons is redesigning care delivery around prevention, innovation, and the patient experience. Plus, we talk about building the next generation Mayo Clinic, scaling robotic surgery, and why the future of healthcare might be fewer hospitals and more high-performance clinics. Let's get into it. The Fitt Insider Podcast is presented by EGYM. EGYM's smart fitness ecosystem is transforming healthcare through exercise. Combining strength equipment with AI-powered software and corporate wellness platform WellPass, it's leading the shift to proactive preventative health. Learn more about EGYM's intelligent workout solutions at egym.com. Hi, Nick. Welcome to Fitt Insider. Thanks for joining us.
Thank you for having me.
Yeah, excited to get into it today. And maybe from the top, we'll give some folks context on yourself and Commons Clinic, like what you're working on, your background, and then we'll go from there.
Yeah, well, I'm Nick Aubin. I'm the co-founder and CEO of Commons Clinic. We're a 4-year-old startup out of LA, building what we think of and talk about as the next Mayo Clinic, taking a venture playbook of building an advanced practice model for multispecialty services across musculoskeletal, so spine, orthopedics, joints, sports medicine, as well as new expansion specialties like bariatrics, women's health, and cardiology, to build what we hope becomes, again, this kind of definitive brand in specialty care with a modern twist, right? Competing with health systems like Cedars-Sinai or Sutter Health, with a product that is kind of ruthlessly more consumer centric, that's more focused on, prevention and health span as much as we are on procedural intervention, and doing so in a lighter weight tech-enabled form factor. So think fewer hospitals and more clinics and surgery centers, all powered by technology. We're in LA today and looking to expand to a couple major markets soon. But yeah, that's us, and that's what we're trying to achieve.
For sure. It's a huge undertaking and huge opportunity, much needed when you look at just the state of, well, any health outcome metric, traditional healthcare system. And I think folks listening to you explain it, those who are deeply in, the healthcare world will understand exactly what you're talking about. Folks who maybe aren't as deep might not get the intricacies. So we may have heard of, hey, we're reinventing primary care for this with a digital first, or we're doing a virtual care version XYZ. How did you land at this model? Why, kind of start in the MSK and expand from there? And what does that specialty care, system look like as you continue to expand?
Healthcare has a lot of problems. The the problem that I think is my sweet spot to unravel is that I believe in almost every market across the country that things are too expensive and care models are not changing because of, frankly, like incumbent hospital systems dominating market share. So take spine care, for example. In a market like LA, over 90% of all of the spine dollars are spent at a facility such as a Cedars-Sinai. They charge, call it over 100 grand just for the facility fee for a spinal fusion. When you actually unpack this, someone walks in with low back pain, right? If you live in another country, you're going to have some conservative interventions. And if you do need surgery, it's probably going to be something very minimally invasive, like an artificial disc replacement or a decompression. You walk into that, same clinic in the United States, best way to make money is to do a spinal fusion. It's a procedure that, frankly, doesn't have better outcomes than anything that's dramatically less expensive and more minimally invasive. And so, you go to Cedars-Sinai, they make a boatload of money on the facility fee, and they've driven up facility fees because of their market positioning, their market share, their power over health plans, and they have this innovator's dilemma now, where like this is their business, right? This is the hospital business. More procedures, more heads in beds, like perpetuating that. And we are here to unravel that, right? And to get care to move out of that paradigm. And I think what we see is really, like rather than trying to get a human being to change their diet or nutrition and prevent it on the front end, there's a lot of companies doing that. There's a lot of companies that are doing great work, whether that's the longevity space or advanced primary care or what have you. A lot of folks are putting in the reps to get that done. What we're really tackling is from a specialty angle. When something happens to you and you need specialty care, how can we really innovate on that care model? And I always say to our team that a lot of this transition is early but inevitable. Things like total joint replacements have been moving into community-based ambulatory environments for a long time, and we have this amazing kind of Moore's law moment happening across the specialty ecosystem, where you have procedures like, your audience has probably never heard of this one, but there's a cardiac procedure called a TAVR, a total aortic valve replacement. And this is a kind of like a very revolutionary minimally invasive procedure for dealing with some heart issues that today is like basically hospital based, and will be moving out as the technology kind of progresses, and will be more both accessible and lower cost. And we want to be building the chassis by which we can drive these innovations. And if that means that we have a fewer hospital systems driving up prices in the future, like, that's the goal.
You're talking a lot of, we're talking tech enabled, Mayo Clinic of the future, Moore's Law, Innovator's Dilemma, like a lot of things from this very, tech focused perspective, which I think is much needed. We talk about a lot on this podcast and even behind the scenes of like, hey, how do we take these frameworks and frankly operators and bring them into whether it's healthcare or wellness or fitness or nutrition, you name it, to really drive things in a new direction, because clearly what we're doing isn't working. But there is this kind of gap or hurdle of lots of different people trying to apply these things to healthcare, them, in many cases, spectacular failures, or, a lot of headwinds to really crack this, whether it's, hey, do we integrate into a system that we don't really agree with or like, that's maybe behind, or do we build an entire new thing and just circumvent it altogether? So like, how do you see where you fit in, and starting with like MSK and orthopedics and then being able to expand?
I have a macro belief that if you're building tech-enabled healthcare, you need to hold the belief that tech is inherently deflationary, right? And it is deflationary because the economies of scale that you get from deploying it, the arbitrages you get compared to an incumbency. And I think the mistake that many healthcare entrepreneurs make is saying that I can replicate what is happening, in person digitally, scale it, and like automatically get outcomes to change. Whether that's like virtual physical therapy, I think is a great example of this, right? At the end of the day, physical therapy works if people do it, right? And if you can increase access to it, cool. And if you can do it at a lower cost, great. I don't know that that is what has happened, right? I don't know that more people are doing physical therapy today than 10 years ago because of technology. When Commons thinks about technology, as I went on that long rant 2 seconds ago, we think about it as, how can we really implement very novel, often med tech solutions to shift care paradigms. So, like an example of this would be in 2018, total joint replacements came off of what's called Medicare's inpatient only list, which is basically this like this hospital regulatory capture that keeps certain procedures needing to be done in a hospital-based facility. All of a sudden, 2018 comes around, and total joints can be done in the surgery center, and they could be done safely. You had new robotic solutions. You have all this technology innovation that made it safe and efficacious to do things like total hip replacements in ASCs. So what do you see? You see price comes down precipitously. You see volume going from 15% of total joints in ASCs in 2018 to now over 50%, right? And you see the total number of total joint replacements about doubling during that period of time. So like that is what we're talking about, harnessing these kind of technology waves to kind of fundamentally change how different specialty use cases are cared for.
Even hearing you like set up the opportunity initially, talking about, you know, the misalignment of incentives, right? You're making more when you're doing procedures, you're charging more because you have this kind of position in the market. The more heads in more beds is how you framed it. Thinking about your opportunity and even leveraging technology and really creating a new space in the landscape, how do you compete or maybe deal with the pressures of a system that is completely backwards, right? Is there pressure from, on you to say, hey, we don't even want something like Commons Clinic to exist because really it's the complete opposite of how the traditional system works, whether that's from the payer environment, whether that's from other hospitals and healthcare systems. Like, do you feel that pressure? Have you felt that? And I guess, do you anticipate as you continue to grow?
There's two approaches to like the problem that we're trying to solve. I think one approach, not to talk shit about virtual physical therapy, like this entire, podcast, but like there's two approaches if you want to, for example, make big change in MSK. One is say, we're going completely outside the system. It's all digital, and like we're going to prevent people from ever even touching traditional healthcare. And the reality is, like, for 99.9% of people, they go on ZocDoc, they ask a friend, like they end up in a physician's office and then like get taken away, right? I think what Commons is doing is I think we are operating from the inside. Truthfully, I think like myself, my co-founder Paulo, like we at the end of the day are healthcare insiders. We're not like ex Googlers like starting healthcare companies. And so I think so much of what we're doing is actually just remixing business models that we know work and kind of putting them together in a novel fashion, which allows us, again, we're deeply competitive to the incumbency, but the way that we are approaching things wins in the way that like other platforms can win too. We're not inventing some business model that didn't exist. We're not doing things that in a vacuum, that one piece of common strategy has never been done before. I think where we see our difference is, and where maybe our superpowers are, is taking all of these different things that have happened throughout healthcare. So for example, surgery centers are a thing, right? There's a lot of different business models there. It's, very clear how you make money there. Rolling up physicians is a thing, right? There's a lot of ways to make that work and pull them together. Taking on financial risks for different value-based care arrangements with health care, with health plans is a thing, right? Like working with employers is a thing. There's a lot of folks that do that, right? I think what with us, we're putting them all together, and so there's a lot of complexity, but the pressures remain the same, right? Have a great product, attract physicians, attract patients, get paid for it, right? And if you kind of capture the value more, less value than you create, then you will always beat the incumbency that just like is foundationally disadvantaged when they cost more, aren't changing, and are not nimble enough to compete with you on a different playing field than they're used to.
So let's maybe look at a couple different pieces of what you just talked about. One is like from the individual and the patient coming in, you like surgical centers are a thing and traditional healthcare is a thing. So somebody walks in to Commons, like whether it's from diagnostics or care plan or surgical intervention or even more conservative kind of treatments, like what does that experience look like? And maybe then we'll go and look how it applies to other
Yeah.
specialty care opportunities.
Yeah. Like honestly, it's pretty simple. It is, go after top decile physicians. So like, we've seen a lot of investor-backed healthcare models that are what's called staff models, which basically means you put a physician on a W-2 and it's kind of a nameless, faceless physician. Like it kind of doesn't matter who that physician is. They're just kind of in a machine. For us, the brand of those physicians, who they are really matters. When someone is, doing spine surgery on you, like you don't want that person to have been trained in Bermuda. Like you want that physician that is trusted in your community. And that's really core to us. Two is like, I hate to like say it this tritely, but like pretty clinics, like a nice environment, not just for our patients, but also for our clinicians to be attracted to Commons and want to practice in, and putting as many services in those sites as possible, everything from physical therapy and durable medical equipment and imaging, like all of that stuff. And then vertically integrating in our own surgery centers. That's where things start to get really, I think, interesting and differentiated. Our surgery centers are like, they are different. The technology that we're bringing into them is different. And that can be things like robotics or advanced kind of endoscopy systems for spine, but it's also like operational capabilities. Like we can have our patients stay for 23 hours. Not a lot of surgery centers do that. It kind of costs more. You got to like set up your operations for it. We have very advanced anesthesia programs and nursing programs, all of which are built to do a higher level of complexity. Like our, purpose for being here is like academic quality care in the community environment. And then I would say like the last piece on this technology front is like prioritizing the procedures of the future. That's, it's kind of a almost like an icky way to say it, but fewer spinal fusions and more artificial disc replacements. Going where the puck is heading with these things is ultimately what's doing right by patients and doing right by the value that we need to create to save money in the US healthcare system.
As you laid it out, it's like the framework that's there, starting with, kind of MSK and going into more specialty care. Was that always the vision to say like, hey, if we can have kind of this front door, and then where from the surgical robotics innovation perspective can we introduce things that what we're getting at now is the kind of more recently launched whole body, and what vertical integration and expansion actually looks like? How do you think like, hey, these are the next one, two, three things that we expand into?
When I and my co-founder Paulo and I started thinking about starting Commons, like, we're healthcare insiders. We've built a bunch of healthcare companies. Like we know how to build some of the business models. But I think what really was happening in our personal lives was my parents over a 10-year period had a bunch of specialty procedures. Paulo, his family had very similar experiences. Like between the ages of 40 and 65, it's pretty predictable what happens, even if you're relatively healthy. It's a total joint replacement here. It's a pelvic prolapse procedure here. It is a cardiac event there, right? Like these are Mount Rushmore specialties. And what I saw was, my parents going to various providers, having various outcomes and quality issues. And, for me, that spelled the opportunity to go build a brand that could address this and own and be kind of the definitive specialty care provider for folks during this really critical period of time in their lives where shit happens. So the vision has always been multi-specialty. I think what has really changed over the past, 4 years since we started the company is specifically, and we talk about this internally, is like people are becoming more health activated. And for folks our age, that might be the blood testing and longevity, and performance improvement, like all that stuff. But I think for folks like my mom's in her early 60s, I think it is more like they want to be more proactive about cardiometabolic health and like making sure that they get CCTA screenings, which is a cardiac imaging procedure, and knowing like, hey, like where am I? Like I don't want to have plaque in my arteries and have a heart attack, right? That's not a huge problem for someone that's 35 years old. It's a much bigger problem for someone who's 50 plus, right? So I was seeing that people are health activated. Last fall, my I was at my sister's wedding, and we had a very kind of unfortunate experience where my uncle was saying he was having night sweats and a bunch of issues, and we were like, oh man, that like you got to go to the ER, like you got to take care of this. This doesn't sound good. And it became like the worst 30 days of my life. He just found lesions on his liver and died 30 days later from bile duct cancer that had spread to his liver. And whether it's cardiometabolic issues or oncology issues or what have you, I think it's clear that we now have a toolkit and a go-to-market model to actually solve these things, right?
Yeah.
If you go get a full body MRI, or you do CT scans, or you do any of these testings with some level of regularity, like you can catch things and you can save lives, right? And I think that was a little bit of the kick in the ass I needed to really lean in and go build it. And so what we see this becoming okay, so what is the whole body program? This is a suite of advanced health assessments that leverage advanced technologies like whole body MRI, like CCTA, like genetic testing, VO2 max, and things that other people are doing, but connecting them to a specialty health system, right? And ultimately taking accountability that if we find something, we will do something. We won't just hand you a piece of paper and say, like, go figure it out. We're taking accountability.
This episode of the Fitt Insider Podcast is brought to you by EGYM. EGYM makes some of the most innovative strength training machines on the market, but that's only one part of their integrated ecosystem. With connected fitness equipment, AI-powered gym software, and a comprehensive corporate wellness offering, it's forging the future of preventative health. Partnering with companies worldwide, EGYM's WellPass program improves employee health by expanding access to premier fitness and health facilities. Upgrading gym floors, EGYM equips every operator with smart equipment and AI tools to create hyper-personalized training plans for every exerciser. Putting it all together, they're transforming healthcare through exercise. Experience the power of EGYM's ecosystem at egym.com. Yeah, super smart, especially given the, as you described it, that kind of shift health aware and being proactive. Because I was going to ask you, it does seem like, and yeah, sure, maybe I'm in a little bit of a bubble relative to, founders in my network and the types of things that we're talking about as it relates to like the broader wellness world, but like the longevity and the panels and the screenings and the testing. And then and as someone who's been fortunate enough to try a bunch of them and do them regularly, like, and then what? I'm still left on the other side of that with like, okay, kind of super grateful to this point that I haven't found something that requires like surgical intervention or specific treatment over time. But it does feel like we need more people on the other side of that going like, okay, and we will handle the thing by not just sending you down the street to the, right back into the broken system that we all just kind of spend a bunch of time talking about, like how we need a different solution. So do you have a perspective on like and again, we don't want to be in a place where it's like, hey, let's just talk shit about other things and categories, but like there's a whole bunch of diagnostic and longevity and preventative health and optimization, but it's like, okay, what about the actual care delivery when we think about shifting this paradigm?
I think that all of this stuff is good, whether it's a annual or monthly blood test, whether it's a full body MRI, even if they don't take accountability for your care. I believe that is better than the incumbent models because people have agency, people can take on things. I actually think that the biggest thing that, or the biggest issue I've diagnosed is that a lot of people starting companies like the ones that we're discussing look a whole lot like you and me, right? Which is, 30 something year old dudes, right? The reality is that, like, commons, like our average patient's 58 years old. The needs of a 58-year-old woman are not that of a 34-year-old man, right? Their cardiometabolic issues are different, their hormonal issues are different, their risk profile is different. And so I think what this whole like kind of longevity testing diagnostic industry has uncovered is a lot of both consumer demand and a lot of tactics to put into place. I think if we have one differentiated insight, it's like we just want to deploy those things for people that are older and maybe they're kind of past the point where they can prevent some of this stuff. And it's more important that we intervene. Those interventions, might be lifestyle, but like in some cases, it's going to be surgery, it's going to be medication, it's going to be like, those things. And so, I hope that commons can be the tip of the spear for people using these technologies to then go do something with it, right? Like I think longevity 1.0, health optimization 1.0 is really going to be about giving people the data. I think 2.0 is going to be a lot kind of more like what we're doing is like target populations and then actually have throughput, right? And that throughput needs to be increasingly more advanced and complex.
There is this, and already starting to hear folks that are squarely in the kind of prevention and longevity care start to think about, okay, what does longitudinal care look like? Like, how do we actually measure this over time? How do we show outcomes? Like, how do we move the needle in a way that is not performative? And especially for, like you said, when you just get right down to it, folks that actually need some type of intervention. So it'll be interesting to see. And I definitely agree. It's like, yeah, we need the momentum, but then we also need kind of the execution on the back end.
We shouldn't walk around and pretend like there's some like magic new solution that's gonna like save the world. Like at the end of the day, so much of prevention is eating well, working out, having a strong kind of life, meaning from like a mental perspective and like everything that can have. And now we have tools like GLP-1s and stuff like that, so it's easier. But behavior change is really hard, and like we have a lot of whether it's like digital health kind of 1.0 with Livongo or the newer solutions that are taking kind of a different packaging of that and more consumer spin. Like getting people to do that is the indelible problem to solve, right? Like changing US nutrition patterns is like that's a problem that, as egomaniacal and ambitious as I am, I don't have that in me, right? So I'm trying to tackle a problem that I feel like I can uniquely solve, but I hope that this, kind of energy can be applied to solving the basal problem, which is that, right? Like telling someone, hey, we looked at your blood test, you're overweight and you eat like shit and you don't work out, like you can use a mirror for that.
The kind of obvious other piece is, hey, how do we pay for all this? And you talked about like being an insider, knowing the business models, having some experience in that world. I'm not gonna claim to be the expert on the various approaches, but from value-based care to the different risk models to fee for service, how does Commons approach it? Maybe why, and like, will that continue to be the case? I mean, some people start in one direction and hey, we hope to kind of
Yeah.
pivot and get this taken care of. So what does that look like?
Yeah. I think for us, like take the services that we deliver. It's a great specialty physician, oftentimes doing a surgery on you in our surgery center. We are delivering a bundle of care. Like that's what we're in the business of. And we need to get paid for the care that we're delivering in the complexity of that care. When we do a surgery, a health plan saves money because it didn't happen in a place like Cedars. And so whether that's a value-based payment, a bundled payment, fee for service, like as long as we get paid for the value that we're creating and it's sustainable for us, we're stoked. As we move into some of these newer categories, I think that we should all be focusing on what is the clinical model that we are delivering? How do we bring the price point to a place where more and more, Americans can access it? In this Venn diagram of like that care model being impactful and price needs to converge, right? I think that it's exciting to see like a cash pay world start to come together because I think that's just indicative of how kind of again health activated folks are. In a perfect world, like I believe that insurance should like largely be focusing on when things go wrong and paying for things like surgery that's unavoidable, and that we need to kind of then give folks basically budget to like go spend, whether it's HSA dollars or cash or whatever, on the building blocks of health, which nutrition, exercise, all these things. So I don't know that I have a silver bullet, but I do think the most important part of like before how you get paid, it's ultimately like what care model moves the needle, and does it have product market fit with people? And if it doesn't, like who cares how you pay for it, right? It should just be paid proportionate to the value it creates.
When we're looking at like the existing, whether it's insurance and payers, like, is there an appetite on their end to engage? Because we're seeing the demand from like the health activated populations that they're willing to spend those dollars. There's a lot more kind of work and effort to be done to get the establishment to shift how they're looking at things. And even if it is more on the prevention side, more technology, more outcomes, like it's a little bit more difficult to get them to see it that way.
Honestly, I think around the edges, but not for the things that I think would move the needle. So a big category that we're talking about are like these advanced imaging studies, right? And whether that's a full body MRI or a CCTA with a company like Clearly, which has very impressive predictive capabilities around coronary artery disease, these are things that are like currently, not reimbursable, and and if they are reimbursable, it's diagnostic, meaning you can't do it pre a CAD risk factor, like a utilization management problem. I think that if we are serious about making these broadly accessible, like it's a literal act of Congress, like, right? It's saying that, hey, we want to do the Imaging Act for America that says everyone can get full body MRI or a CCTA preventatively, and the government is going to, CMS is going to put it in their fee schedule, and then health plans are going to be mandated. There's precedence for this. There's a Women's Health Act, I think, of like 2012, that has enshrined things like prophylactic mastectomies for breast cancer, have to be covered by health plans. If we want to do that, like, we as a country can make that happen, and people need to advocate for it. I think some of the people that are delivering these cash pay services may not want that to happen because it'll end up driving down the cost of it.
Yeah.
But like, ultimately, like, I believe these technologies can have massive impact, and we should be advocating for them to be as affordable and at scale as possible. And the reality is that, like, the vast majority of these things have to be policy driven. Otherwise, they will just, like, health plans follow policy and they follow CMS, and that's just the way the world works.
One of the things that's actually, well, a lot of things can be, but one in particular that's infuriating is we talked a lot about these preventative scans and different longevity companies and all that. And it's like going through that experience and having results come back and getting answers to, not life threatening or serious conditions, but, looking at it and having the doctor review it and they say, oh, does your low back hurt here? And it's like, oh, that's because this is weak. We can see it here. You would want to do a corrective exercise this way. Oh, do you have pain here? Oh, we see a cyst. It's not serious, but we want to keep an eye on it. And that explains why there's inflammation. And to your point, it's like, if there were some declaration where it's like, we kind of already know what to do. Like if we're serious about prevention and solution and then tackling some of these chronic issues, like, well, then yes, we do need to be catching them earlier. And it's like, but we already know that. And if we did it, we could, and then we could put an intervention in place. And then, but it's one thing to talk about a broken system, and then it's one thing to like see it in action and be like, oh, like we already know, like I already, like the answer is already there. We're just like not doing anything about it. We're just going to wait till this gets so bad that I have a bulging disc and now I have to have some type of more serious intervention. It's like that's maddening.
Yeah, and you take that use case of low back pain as an example, and what you just walked through is you had to go to a physician to tell you that you needed to strengthen your back, right? If you asked a couple minutes ago about, like, what sort of payment reform, or like, what would I advocate there, it's like, I personally don't think primary care is the answer to the use case that you just espoused. It is, 2, 3, 4, 5 years before that, going to the gym, right, and being, like, physically active, and, like, that's not going to prevent everything, of course, but on the average, it is. It's like, I would be very pro government funded Equinox. I mean, these are, but I don't think that is, how our current insurance environment is architected, right? It's like, we can do things like pay for capitated primary care. I would love for, to qualify to be a Medicare, like, primary care provider in a value-based relationship. I would love for you to have a gym or offer gym memberships as part of that. And so, again, like, I'm probably preaching to the choir with a lot of these things, but we should be looking at ways to scale the things that just foundationally work, and not try to jerry rig a system that's not working with a new way of paying people and expect change to just foundationally happen.
A couple more questions before we wrap up. One being, just what do the physician partnerships look like? Because that as another opportunity of being differentiated and helping where there's a lot of burnout, a lot of disillusionment, like, and frustration. So this being an opportunity to really bring in, you don't want to say that folks at traditional healthcare aren't high performing, but like bring those people in and maybe incentivize them in the way that they don't currently have.
Foundationally, our approach to this is we need to equitize our physician base. And I think that, whether it is, this trend of independent physician groups kind of struggling and being consolidated by health systems or private equity or what have you, I think it has led to the called under equitization of physicians in America, meaning that not just that they don't economically own their practices in the same way, but they don't own their care models. It's one thing for me to sit here, not a physician, not clinical, and like tell someone what to do, but like ultimately physicians are the drivers of clinical innovation, and they need to have equity not only in their practices but in the clinical programs that they're developing. They need to believe in it, right? And I think if we've done, one thing, it's attract high agency physicians that want to own their practice. And when I say own it, I mean within the Commons umbrella, but like own what it means to be Dr. Eric Milstein, orthopedic surgeon in LA, right? And like the ethos by which you practice, and not have some suit telling you what to do. And then for us to learn from them and harness that to scale it. We've done some things like structurally to make that happen, rather than an employed model or some of these other ones. Like it's a GPLP structure. Our physicians are owners in the group, right? And I don't think they would ever call themselves franchise owners, but they are owners of the Commons franchise, and they are building and collaborating to build their brands and the collective brand together. And I think that aligned incentives, and then also canvas for them to put their care model vision into practice, is I think what's attractive. This is in some ways modeled off of what the Cleveland Clinics, Mayo Clinics, MD Andersons have been able to achieve. It's like put the best people under one roof, give them capital and resources to kind of go drive innovation. We're just doing that in a different model with different goals than maybe that research, therapeutic kind of like structure at an AMC.
Taking this and looking, even further ahead, if we zoomed out, like the various approaches and companies, like we mentioned, difficult to disrupt an entrenched, multi-trillion-dollar industry that really has no rhyme or reason to do anything differently. That's a lot of time, right? That certainly doesn't happen overnight. So this is
Yeah.
a multi-year, even more than the typical whatever startup journey, and expensive, right? A lot
Yeah.
of resources. You just raised, I think it was 26 million, and so continuing to expand. Like, do you have, like, what does this roadmap look like? How do you kind of process the journey and what it will take to, achieve and see something like this through?
I'll be like, listen, I think like in many ways counterintuitively, like building full stack vertically integrated platforms, they can be profitable pretty early because of it's a tried and true model. Like it's not the same as an advertising driven, more like venture kind of like software scale like P&L use case. So I think for us it's about being disciplined, building a model that really resonates with the communities that we enter, but is like sustainable by default, and rinsing and repeating. I kind of come from the school of thought of, I mean, everyone loves Warren Buffett, right? One of his great Warren isms is like he wants to invest in companies that he can put like infinite amounts of capital in at a high rate of return, right? That should be the goal of a business like Commons Clinic, to be able to continually invest in expansion at a very high rate of return, not just financially, but also in the impact that we make in the markets. I I have no interest in building like a national like virtual platform that has like 0.000 X% market share. I have a whole lot of drive to go into major markets and have 25, 30, 40% market share in specialties that really matter to that community. Because if we do that, we've not only built a really big business, but also like driven up access to innovative care, driven down the cost of that care, and also, caused a chain reaction where others now need to adopt what we're doing, or they'll be put in a place where the dinosaurs go extinct.
I think a lot of folks will be interested to follow along. We certainly will be. And for folks that want to learn more, is website, like social, is the best place to keep up with you going on, or anything else that you would point them to?
I would say like if you're interested in like being part of this journey. Like, I'm not super active on social and all that stuff. Just email me, nick@commonsclinic.com, and I'm open for business.
Perfect. We will get all the other stuff, where to find more, in the show notes, and super excited to share the conversation. Appreciate you spending some time with us today.
Thank you very much.
Thanks for listening to today's episode. If you got value from the conversation, please consider subscribing and sharing the podcast with a friend or colleague. It's a massive help. And if you want more content like this, including news and insights on the latest industry developments, subscribe to the Fitt Insider newsletter at insider.fit.co. And one more thing, you can learn more about our recruiting and consulting services at fit.co. That's FITT.co. I'll see you here next week.